This evening, we're privileged to start our fourth session of the CME series, focusing on liver transplants. And we have the pleasure today of having very distinguished speakers. One from our country within Uganda, a very highly respected surgeon and a leader in the field of hepatobiliary surgery and surgery in general. And one from our partner hospitals, whom we shall introduce closer to the time when we shall speak. And thereafter, we shall have another presentation from Mega Care, our dear partners and sponsors. Then we shall call it a day. Without wasting much more time, I would like Dr. Kituuka to prepare to take leads in the presentation. Then we shall follow in that order. At this point, Dr. Kituuka, if you're ready, we'd like to welcome you to kickstart the day's events. Thank you so much. Oh yes, we can hear you now.
Okay. So I'll get straight to the point. So this evening, we're going to be talking about complications of liver transplant. And just to start us off, I would like us to just, this presentation for me has a special attachment because as you can see on that screen, we have one of our late colleagues, Dr. Peter Ongom, who passed away, I think it was in 2015 or 16, following losing a battle to following liver transplant, which had been done in India. And the images you see there are our departed colleague and his brother, Charles, who was the donor for him. Dr. Peter Ongom passed away about 2.5 months after having undergone a successful liver transplant, but he came back to Uganda and passed away about 2 weeks after the surgery, 2 weeks after returning to Uganda. He died of acute rejection of the donated liver. So some of the things that we're talking about here, we've actually experienced, and we're probably going to experience more when we start doing liver transplant. So as a way of introduction, of course, we've already had a lot of talks about liver transplant. I'm just going to give an overview of just the indications for liver transplant. And there are several. And you can see there are malignancies, acute hepatic failure, cholestatic liver disease in patients who have primary sclerosing cholangitis, primary biliary cirrhosis, secondary biliary cirrhosis, and then non-cholestatic cirrhosis, which can be caused by non-alcoholic steatoric hepatitis, and then as complications of hepatitis B and hepatitis C viral infections, and then metabolic diseases like Wilson disease, glycogen storage disorder type 1 and type 4, and tyrosinemia, biliary atresia, liver cirrhosis, alcoholic liver cirrhosis, and complications of end-stage liver disease. Some of the complications of end-stage liver disease are recurrent variceal hemorrhage. Patients have portal hypertension. They may have severe jaundice and hepatic encephalopathy. All these are conditions that may end up necessitating liver transplantation. Why I'm talking about the contraindications of liver transplant is one of the ways of managing complications of liver transplant is not to do the liver transplant in the first place if it shouldn't be done. So if a patient already has untreated spontaneous bacterial peritonitis and sepsis, these are patients who may have ascites and decompensated liver disease and end up developing bacterial peritonitis. Patients who have advanced cardiopulmonary disease, those who have extrahepatic malignancy, for example, if they have a malignancy in the liver, but they also have evidence of that malignancy having gone elsewhere. So we're talking about advanced malignancy. Active alcohol or substance abuse, this is usually a challenge, especially for those who have alcoholic liver cirrhosis. Many of those will not be candidates for liver transplant if they're unable to stop taking alcohol. And then those kind of patients who are unable to comply to lifelong immunosuppression therapy, these are patients whom you will not do the liver transplant in the first place. There are other relative contraindications, liver transplant, but I will not go into those. Another overview about the types of liver transplant. We have the orthotopic or cadaveric. This is the commonest type of liver transplant. Cadaveric means it's got from a deceased person, and you take the whole liver of that person and you put that whole liver into the recipient. It's usually technically easier, more likely to be successful. However, the challenge is that you have limited organ availability. You have to have donors, and that can be one of the challenges with organ donation and transplantation, especially for liver transplant. Living donor is good, whereby you have a donor who gives part of his liver, his or her liver, to a recipient. In these kind of patients, you have a shorter ischemic time, and because the surgery is usually planned, compared to the orthotopic liver transplant, whereby it is opportunistic. As soon as you get a donor is available, then the recipient has to come and the surgery is more or less done as an emergency. So you can plan this surgery. The challenges you may have is that you have a smaller graft size. You're taking part of someone's liver, not the whole liver. And there are higher risk of complications. And the complications here, you have to consider complications with both the donor and the recipient. Split liver grafting is using cadaveric liver, but in this case, you get, instead of giving the whole liver to one recipient, you have multiple recipients. So you may have one recipient getting the right lobe, another getting the left lobe. It, however, comes with technical difficulties of sharing blood vessels and attaining good biliary drainage because of having smaller portions or smaller sizes of the graft. So what factors will affect post-transplant outcomes? What are the factors that are going to bring about possibility of complications? There are factors that are donor-related, that are recipient-related, and then surgical factors, and then just generally post-transplant complications. I like to look at it in this way. When you look at donor-related factors, you know that living donors are more likely to have complications than, as in living donor transplantation is more likely to have complications than cadaveric, orthotopic, or split liver donation. If you have a patient who has had a cardiac death, then you know that these patients already have the donors have a shorter, the ischemic time becomes longer. People who are older, people who have recipients who have high body mass index, those who have macrovesicular graft steatosis, and then ABO incompatibility. These are all donor related. Then as far as the recipient is concerned, if the patient has a history of primary sclerosing cholangitis, you know that this is likely to give problems is going to develop post liver transplant complications. The recipient has history of cytomegalovirus infections. They have hepatic artery thrombosis. If they have hepatic artery stenosis, of course, ABO incompatibility. Many of these factors we usually try to mitigate them through good donor and recipient matching. And then there are surgical factors. These are the surgical technique. If you have excessive dissection of periductal tissue, you'll have complications. We will go into the complications in more detail, but this is just an overview. If you have excessive use of electrocautery, this will eventually cause problems, may cause problems with the biliary ducts. It may also cause problems with the arteries, especially the hepatic artery. Tension at the anastomosis. If you have a small bile duct diameter of the graft, if you have a mismatch in size between the recipient and the donor bile ducts, if you have prolonged ischemic times, cold and warm ischemia times, And then you have other factors that come from ischemia and reperfusion injuries. I'm going to go into the details of the complications, but we first need to look at them in terms of how we can classify them. We can have complications that are early or late. We can have them according to the structures affected, that is the vasculature or the biliary ducts. We may have complications that are associated with the surgical technique, like we have talked about in the previous slide. Then we have those complications that are due to medical conditions or the non-surgical aspect of the liver transplant. And then complications that come from adjunct treatment. This may be, again, in relation to the non-surgical aspects of liver transplantation. And then you can also classify them according to when they come and how long they last. So you have long-term complications versus short-term complications. So the technical complications that I'm going to discuss, one is hemorrhage, others are vascular complications, then there are biliary complications, and then there are non-specific complications. So when you're looking at those that are non-specific, I'll talk about the non-specific ones because I'm not going to discuss them again later. These may be caused by infections. These are other complications that come about from surgery generally. They may get small bowel obstruction. They may get injury to other adjacent intra-abdominal organs. So those ones, I will just talk about them briefly now, but I'm going to focus on the other complications that are more technical. So how do we have hemorrhage in patients who undergo liver transplant? Many of these patients sometimes have severe coagulopathies and thrombocytopenia, which can cause hemorrhage. And then if initially the liver has very poor function and is non-functioning, so those are already candidates for getting hemorrhage. If during the surgery there are a lot of liver lacerations, you can bleed from those. You can also bleed from a leak of the anastomosis of a vascular anastomosis. That can also cause hemorrhage. Then hemorrhage can also be heparin induced because these patients we're trying to minimize formation of thrombosis within the vasculature of the liver during the liver transplant. So these patients may be on heparin, and that can also cause hemorrhage. Then sometimes patients have to undergo post-op interventions. For example, liver biopsies. These are patients who, for example, if you suspect that there's acute or chronic rejection of the liver, the confirmation is by a liver biopsy. And sometimes when you have these liver biopsies done, patients end up getting hemorrhage because they already have, in combination, coagulopathies and other problems that can predispose them to hemorrhage. Then patients who get hepatic artery stenosis or thrombosis, which is more common in children who have received liver transplant more than adults, these can also end up having hemorrhage. This is because they have it's usually caused by a small vessel diameter or underlying atherosclerosis or Lienales-Steele syndrome. Lienales-Steele syndrome is I'll describe that a bit later. And then where you have a small donor celiac trunk and a small donor common hepatic artery. These are candidates of hepatic artery stenosis and thrombosis, and eventually they actually end up having hemorrhage. So how do we manage hemorrhage? Of course, we have to correct the coagulopathies, and this can be preferably preoperatively, and intraoperatively, we may have to also give all these other things like vitamin K, fresh frozen plasma, platelet infusions. You may have to give tranexamic acid. All these are trying to manage hemorrhage. Of course, you have to have a meticulous surgical technique. So your anastomosis is careful to make sure that you don't have leaks of your vascular anastomosis, and you have to make sure that if there's any leak from a vascular anastomosis, that is repaired as early as possible in the postoperative period to prevent further damage. And then you have to make sure you have appropriate matching of the graft size and vasculature for for donor and recipient. So when you go to hepatic, to the specific complications, we're going to talk about the vascular complications. And the first vascular complication we're talking about is hepatic artery thrombosis. Hepatic artery thrombosis is the commonest vascular complication, and it's the most feared. Why? First of all, it occurs in the within the first 7 days post-transplant. It may occur late, and when it occurs late, it has an insidious appearance, and you'll find that the patient will present with features of biliary duct ischemia and biliary complications, as opposed to the other complications that you may see in early onset. With early on, it's more susceptible for pediatric liver transplant compared to the adult liver transplants. And the predisposing factors are where you have multiple recipient arteries. So you may be trying to anastomose several arteries. If there's celiac trunk stenosis, if there's Lienali-Steele syndrome. Lienali-Steele syndrome is whereby you have blood going away from the portal system and the arterial system and going into the spleen. So when most of it is going through the splenic, through the spleen and through a portal splenorenal shunt, you have less blood flow within the hepatic artery. And because the blood flow is slow, then it predisposes the patient, it predisposes the recipient to getting thrombi in the hepatic artery. If there are multiple donor arteries that require reconstruction, this goes again together the multiple recipient arteries. So then you have a higher risk of getting hepatic artery thrombosis. If during the retrieval of the donor organ, you have damage to the intima of the donor of the hepatic artery, this can happen sometimes when you have taken out, you've harvested the donor liver, and you look at the hepatic artery and you find that there's a thrombus in there. And that means you do the thrombectomy before you transplant that donor liver into the recipient. In the process of doing a thrombectomy, you may cause damage to the intima, and that then predisposes that particular hepatic artery to forming a thrombus. Again, ABO incompatibility will cause thrombosis, and then also prolonged cold ischemia time. How do we diagnose it? The patients who present, they may get fever and sepsis, mainly because with hepatic artery thrombosis, you have reduced blood flow to the liver that can end up causing infarcts in the liver, and these may eventually cause features of sepsis, like fever. We diagnose it also by imaging. You will start seeing, you can do a Doppler ultrasound scan and look at the flow in the hepatic artery, or you do an MRI angiography and you're seeing reduced flow and a presence of a thrombus. And if you're doing a blood test, lab investigations, you'll find that you start seeing increase in the transaminases, AST and ALT. So how do we manage that? The first thing is to avoid injury to the intima of the hepatic artery. So as much as possible, you try to avoid manipulating the intima of the donor hepatic artery, as well as the recipient, but most times the injury tends to occur with the donor. Then you have to need to diagnose this early. And this is done by frequent Doppler screening from day one post-transplant. The frequency, as in whether it is done daily or every 2 days, will vary according to the different centers where this is done. But you may find in some places they're doing it daily, others are doing it every 2 days or every 3 days. But the point is that it is done frequently and it's done early within the post-transplant period. Sometimes you have no choice have to go back and do a retransplantation and reanastomosis of the hepatic artery. You may also be able to do thrombectomy, and this may be done by interventional radiologists to help with restoring vasculature and blood supply through the hepatic artery and removing the thrombus. Another complication is hepatic artery stenosis. This one tends to occur later. It may occur around 100 days post-transplant. That's when you may see some symptoms. And these patients, this is usually the patients who you may see elevation of AST and ALT, just like in the hepatic artery thrombosis, and features of fever and sepsis because of ischemia and infarcts occurring in the liver. The things that may predispose you to getting hepatic artery stenosis are if you get clamp injuries as you're clamping the hepatic artery during the process of retrieval from the donor, and then before anastomosis to the recipient. That can cause injury to the intima and to the artery, and that can end up resulting in stenosis. Of course, if you're having a poor surgical technique, very many sutures, and you can end up with a lot of cautery around the hepatic artery, then you can end up causing that area to get stenosis and fibrosis. Then the other problem that can occur is a donor-recipient size mismatch. This is a size mismatch between the hepatic arteries of the donor and the recipient. Sometimes that's not very easy to achieve, and so you know that if you find that the hepatic artery of the donor is very small compared to that of the recipient, then you're likely to get stenosis and other challenges, including even hepatic artery thrombosis. The main treatment for this is balloon angioplasty and stenting. These are done by an interventional radiologist. Then we look at portal vein thrombosis. Portal vein thrombosis, this is less common, but when it does occur, it occurs early, in the early post-transplant period, and the patient presents with features of portal hypertension. So they will have they may have variceal hemorrhage, they may have ascites, they may even end up presenting with fulminant liver failure as the blood supply to the received organ is reduced. And that ends up with allograft dysfunction, and you'll see that in the liver function test, elevated transaminases, elevated bilirubin levels, and problems with the PT-INR, all those that will show liver failure. It carries a high mortality, and therefore you need to know the predisposing factors. Things that will predispose you to a portal vein thrombus is portocaval shunts, a patient who has had a previous splenectomy, and there's again donor-recipient size mismatch. If there's a pre-existing thrombus in the donor liver, if there are large portosystemic collaterals, the large portosystemic collaterals also mimic the Linealis-Steele syndrome, whereby you end up with decreased portal flow, and that ends up predisposing one forming thrombi. And then if you have a redundant portal vein and there's kinking and torsion, that can also end up stimulating the formation of a thrombus. And then if there's allograft edema then makes the flow, impedes the flow into the graft, and that ends up giving you thrombi. It's diagnosed by a Doppler ultrasound, and these are usually done daily in the immediate post-transplant period to ensure that portal flow is there without any thrombi. It can also be diagnosed using MRI angiography and CT angiography. We do not want to wait until the patient gets symptoms of portal hypertension. So we need early diagnosis is through early imaging. The treatment is re-exploration and thrombectomy, or the patient can also be put on anticoagulation therapy, and also they can do a portosystemic shunt. These are just some images of a portal vein stenosis. This is different to portal vein thrombosis. It's not common, but it can occur, and it's diagnosed Again, the patient will have features similar to portal vein thrombosis or portal hypertension. And when you're diagnosing it, it's mainly by radiological imaging. So you have to be able to differentiate. Radiological imaging will help differentiate whether the patient has a stenosis or a thrombus. And here, these are some images of what a portal vein stenosis can look like. And you see the top image is a Doppler scan, and you're seeing the flow not going through a certain part. And that shows you that there's a stenosed area. And then the one below that is the angiography, MRI angiography and CT angiography, where you can see the stenosis, the stenosed area. And the image that is marked D shows you a guide wire that is going through the stenosis, the stenosed area, so that a balloon dilatation can be done or stenting can be done across the stenosis. We also have venocaval stenosis and obstruction. Venocaval stenosis tends to occur later. It can occur about a year post-transplant. And this can occur on different portions of the inferior vena cava. We have this, of the vena cava, we have the suprahepatic, retrohepatic, and infrahepatic portions of the vena cava. Stenosis at the suprahepatic part of the vena cava is more dangerous than the infrahepatic one. This is because when the stenosis occurs in the suprahepatic region, you have reduced graft venous outflow, which ends up giving the allograft edema, and that back pressure can cause hepatocyte damage and other and graft failure. Then you also have reduced venous return to the heart, and that again now affects many other structures, not only the liver itself, but the kidney and other structures as a result of reduced venous return to the heart, and therefore reduced supply to the rest of the body organs. And then the patient will present with hepatomegaly. Hepatomegaly is usually due to the backflow and caused by reduced graft venous outflow, especially for suprahepatic stenosis. And then the patient may also present with edema and ascites. This is especially for the infrahepatic stenosis. And then they can have decreased renal function and liver failure. Predisposing factors are the surgical technique of your anastomosis. If you can end up if you have so many sutures around the anastomotic site, that can also predispose the anastomosis to narrowing and fibrosis. Then if you have a long supra and infrahepatic vena cava, these can cause kinking, and that can end up also giving you some kind of obstruction and stenosis. Then if you have large donor graft and small recipient, this is generally, again, back to the donor and recipient size mismatch. That will predisposes you to stenosis. Then if you have a patient who has Budd-Chiari syndrome and they get recurrence of the Budd-Chiari syndrome, then they end up getting stenosis of the vena cava. It is again diagnosed by a Doppler ultrasound scan, CT angiography. The treatment is urgent retransplantation, especially for the suprahepatic stenosis, because of the problems it causes that I've already mentioned. Then for infrahepatic and other, even retrohepatic obstruction or stenosis, you can do balloon dilatation and stenting. This is a case report we did when I was in India, where we got a patient who developed a complication of inferior vena cava thrombosis. And this patient developed it about 8 weeks post-transplant. They got a thrombus, and then they ended up having, they did intravascular thrombolysis. This was by an interventional radiologist, and then had stenting done. And this thrombosis and subsequent problems that required stenting came about because of a twist in the inferior vena cava. And this is kind of showing you how along suprahepatic or infrahepatic inferior vena cava during the anastomosis can twist or kink and then end up giving you thrombi, and then you end up with this complication. So these complications are real, and they are not just theoretical, they actually happen. And we did see one of these during my training in India. Now we're going to talk about the biliary complications, and the complication will start with the commonest is the biliary strictures. They account for about 40% of all biliary complications. You may have biliary strictures that are at the anastomosis. Those are anastomotic strictures. And these are usually can occur at the bilioenteric anastomosis or at the end-to-end anastomosis of the bile ducts. They are more common among living donor liver transplants. Then you can have the non-anastomotic strictures. These occur at other ducts that are not part of the anastomosis, that are not undergoing anastomosis with the donor, between the donor and the recipients. And these can be from papillovatary ducts and other bile ducts. And these ones tend to be multifocal. Predisposing factors remain the same. Donor recipient size mismatch, longer cold preservation. If you overskeletonize the bile duct and you cut off the blood supply, you end up getting ischemia and then you have healing by fibrosis, which ends up forming a biliary stricture. Then for the non-anastomotic strictures, these are the ones that are not from other bile ducts. This can be due to reduced hepatic artery flow. When there is reduced hepatic artery flow, the hepatic artery is the main supply of the ducts. It results in biliary duct ischemia. Ischemia then results in healing by fibrosis and strictures occurring. Then people who have primary sclerosing cholangitis, this again can also cause biliary strictures. And the diagnosis is mainly by imaging. And the patients, of course, we may present with features of cholestatic jaundice, and depending on where the level of obstruction is. But the main diagnosis, some of these patients, you find that you may find biliary strictures in patients who have T-tubes. Sometimes T-tubes are placed after transplant, and when you can use that T-tube to enable you to assess the biliary tree through a T-tube cholangiogram. But otherwise, in the absence of T-tubes, the patients can be diagnosed using ERCP or MRCP or PTHC. So the images that you're seeing, image A is an MRCP, and you can see a stricture within the common bile duct where the arrow is pointing. And then that same stricture can also be seen on ERCP. And you can see there's a guide wire in there. Preferably, the advantage of the ERCP in diagnosing the strictures is that at the same time, an intervention can be done. And the treatment can be stenting via ERCP, or you can have a PTHC done and drainage, and then a Roux-en-Y hepaticojejunoscopy can be done as open surgery. Or you can end up having to do elective retransplantation. But most times the first two treatments, especially ERCP and stenting, are good for those, especially for anastomotic strictures. For non-anastomotic strictures, you may find yourself having to do a PTH drainage. Bile leaks. These tend to occur early, and they may occur at different sites. They may occur at the sites of T-tubes that are placed during the transplant. They may occur at the sites of the end-to-end biliary anastomosis, or they may occur from aberrant bile ducts or accessory ducts of Luschka within the gallbladder fossa bed of the liver. The patients will present with biliary peritonitis, they may present with sepsis, some may have with features of cholestasis and fever. if there's an infection coming in. It carries a high morbidity and mortality for large leaks, but you can have also small leaks. Predisposing factors: if you have too many sutures on the CBD anastomosis, you can end up actually, in the process, you may think that you're trying to prevent a leak, but in the process, you may cause ischemia and damage to part of the anastomosis and end up with a leak instead of trying to have a very secure, instead of having established a very secure anastomosis. If there's a long donor CBD, sometimes these may twist or may pull and end up giving you a leak. This can also occur as a sequelae of hepatic artery thrombosis for the non-anastomotic leaks. As I mentioned earlier, you may get strictures, but also with ischemia, you may end up having these ducts, other ducts opening out and giving you leaks. The diagnosis is again by imaging, apart from the clinical features, and you'll do an ultrasound, a CT scan, an MRI will show you a fluid collection. Many times you may not know that it's ascites, but sometimes the collection is local within, around the liver bed or within the liver parenchyma. And hepatobiliary scintigraphy may also be used for active leaks. It may show you an active leak. The treatment, you have to first control sepsis if it's there, and you're going to give antibiotics. ERCP and stenting at the site of especially for where there are end-to-end biliary anastomosis, like the CBD, that can also help control a leak. And then you may have to do percutaneous drainage and stenting, plus or minus stenting for large leaks. Then the other immunological complications. These are acute graft rejection and chronic rejection. Acute graft rejection is rare. It's usually mild, but it can occur within the first 90 days post-transplant. Unfortunately, this is what our late colleague succumbed to, and they present with sepsis and liver failure. With chronic rejection, can occur later, and it also results in allograft dysfunction. You may start seeing elevation of the transaminases, the patients get cholestasis, they may get other features of liver failure. And they can occur because of recurrence of the primary disease, or in patients who have primary sclerosing cholangitis, or patients who have primary biliary cirrhosis. The diagnosis, as I earlier talked about, is through liver biopsy, and histologically you will see features of ductopenia and cholestatic jaundice. Then we have the medical complications. These are the other ones I was talking about. So you may have postoperative infections like pneumonias, and these pneumonias may be bacterial or fungal. Fungal, we're talking about aspergillosis. These can occur especially in patients who are in ICUs and intubated on ventilators. These are where some of these infections can come about. The patients can also develop cholangitis and sepsis. And other complications may be recurrence of the primary disease. As we had already mentioned, things like primary sclerosing cholangitis, biliary cirrhosis, hepatitis, all these can actually occur. Then there are those that are related to immunosuppressive treatment, the drugs, and these can cause toxicity. They can cause nephrotoxicity and neurotoxicity. And these are features that we have to look out for in patients who are post-transplant and on immunosuppressants. Then, paradoxically, these patients can also develop hypertension and diabetes as also a result of complications of the immunotherapy, immunosuppressive treatment. Then we have what we call the long-term complications of immunosuppressive treatment. And this is just a diagrammatic presentation. I picked this from a presentation online. And these are also things that we have to look out for. They're not necessarily directly as a result of the liver transplant, but because of the immunosuppression therapy, and these are just a number of them that we have to look out for in our patients. Then there are other complications that can occur. You can get post-transplant malignancy. This can be because of recurrence of the primary malignancy, HCC, cholangiocarcinoma. It can be as a result of immunosuppression. You can get malignancies that come from immunosuppression therapy, like Kaposi sarcoma, non-melanotic skin cancers. Then you can have metastases that can come into the donor, into the recipient, from the recipient into the recipient liver. And then you can have post-transplant lymphoproliferative disorders. Then you can also develop the patient can also develop post-operative fluid collections. These can be seromas, biomas. Biomas will be from leaks. The patient can also develop hematomas from hemorrhage, abscesses, and the management of these, usually drainage for large hematomas and seromas and biomas. Abscesses may need drainage and also antibiotics. Otherwise, those are some of the things that we are likely to encounter as we prepare to start our liver transplant, conduct our first liver transplant, hopefully by the end of this year. And we hope to be conducting it at the Dr. Rita Moser Transplant Center, which is located at Rubaga Hospital. Thank you. I hand over to the chair and welcome any questions, or maybe we'll take questions after the next presentation. Thank you.
Thank you once again. You've received several rounds of applause from the audience on this side, and from online as well. We thank you for that elaborate presentation, and we are moved that you dedicated this presentation to our fallen colleague. At this time, we shall invite any questions, clarifications, additions to Ms. Kituuka's presentation, if any.
Good evening, everyone. Am I audible?
Yes, you're audible.
Yes.
Yeah. Can I request Dr. Olivia to stop sharing screen so that I could? Yeah. Thank you so much.
There appear to be no questions on this side. I'll just leave a small comment that because the presentation is about complications, it seems that the complications are very many, perhaps very frequent. It might leave one a bit scared about the treatment of liver transplant. So perhaps you can give us a small reassurance about the rates of the complications and the success of managing the complications as we summarize, and after that we shall begin. We shall gradually Mr. Lucas.
Yes, thank you. So as you can see, most of the complications, the first thing with complications is to be able to prevent them. And many of them are preventable. And that is mainly in the area of making sure you have good donor recipient matching in terms of, apart from the obvious compatibility, histocompatibility, ABO and all that, but according to the size of the graft, according to the size of the expected size of the ducts and the arteries, these are all things that can be done earlier so that you're able to achieve the best that you can. Also, you'll find that many of these complications can be, you need to be very friendly and also have very good interventional radiologists, because many of these can be sorted out without having to go back and do retransplantation with the help of a very good interventional radiologist. So as we start liver transplant, the presence of a good interventional radiologist is able to handle many of these complications, but otherwise they are manageable, and the patients tend to be able to recover well if they are detected early. Usually the problem is when they are not detected early. So it means just having a very close monitoring and following up these patients, because you anticipate that this could happen. And you also anticipate when they can occur. So you try to look out for them very early before the patient goes into more bigger complications like portal hypertension and decompensation and liver failure. That is really the key. Early diagnosis. Early diagnosis then results in quick treatment and preventing further complications. Thank you.
Right, thank you, Mr. Kituuka. And that is a very good parting shot that actually leads us directly into the next presentation. Oh, there might be one question before you go.
So can I be allowed to share screen?
Thank you very much for the organizers and everyone else attended. My question is to Dr. Kituuka, and I'm wondering whether there's any other African country that's actually doing this liver transplant surgery, and if it's there, I want us to compare statistics of what's the survival rate of the patients that have had the liver transplant surgeries. Oh, yeah, going to be a surgery where almost all patients will end up dying.
Thank you for that question. I don't have the statistics off hand. I do know that they are being done, liver transplants are being done in Egypt. They do a lot of liver transplants in Egypt. I think also South Africa. I'm not sure whether they have started doing them in Kenya, but they're also in the process of advanced stages of conducting liver transplants. But yes, they are being done in African countries. As for the survival, I also cannot give you those statistics, but I can say that at least I've seen at least about 3 or 4 patients who have had one of the patients is relatively high profile, but had liver transplant done it's probably now 9 years ago, and is still alive and well. And so it more or less the survival is also tagged according to the indication. So those who have malignancies may tend to have a lower survival rate than those who have, for example, who had liver transplant done, for example, due to liver cirrhosis or hepatitis. So those are some of it depends on the indication for the liver transplant surgery, but I don't have the statistics on hand.
Okay, thank you very much, Mr. Kituuka. We are getting ready for Dr. Dharmesh Kapoor. And as Mr. Kituuka said, early diagnosis and intervention is key to managing these complications with good outcome. At this point, we're going to invite Dr. Dharmesh Kapoor, who is a senior consultant hepatologist at Yashoda Hospital in India, which has been partnering with many hospitals in Uganda, including the Hospital and others, in developing and advancing medical care. Now, Dr. Dharmesh, anytime you'll be able to start. Yes, your screen is visible.
Yes, it is.
So good evening, everyone, and thanks for the opportunity. And I think Dr. Olivia has set the stage for me to take over this discussion further. And I was not absolutely certain of what her topic of discussion was going to be, but I think she's given a very broad overview of the various complications that one encounters in liver transplantation, especially from the surgeon's perspective. But I think she hit the nail on the head by saying that the key to salvaging the graft as well as the patient is being able to detect these complications earlier. And I would also go on to add by saying to be able to preempt a complication. So the people who've been caring for a given patient would know the entire situation in which the transplant has happened, which includes, broadly speaking, the donor characteristics, some of which are not changeable in the context of deceased donor transplant as well as living donor transplant, some of the recipient factors, which are again not changeable, and then whatever goes on in the operating room. So no two liver transplant surgeries might be similar, even though the patient profile and the indications for which that surgery is being performed might be the same. So I think whatever goes on in the operating room, it's very important for those caring for these patients when this patient returns to the ITU, as well as the transplant physician who cares for this patient subsequently. If they have a fair idea of what went on in the operating room, that will help the patient management. Now, this is broadly speaking what I'm going to be talking about because I think we are running a little late. So I think it might be in the of things to just talk about from being happy with the way the graft looks, which should be a pink soft graft, not turgid, not purple, not patchy areas of perfusion. And then we all know that you have to have a good hemostasis secured before the surgeon decides to close the abdomen. And much before that, as the anastomosis are being performed, an intraoperative Doppler is done. And what we want to see in a Doppler is what you see in this particular slide, the top panel showing the hepatic artery waveform. And I would talk about this in some detail in the subsequent slides. And then the venous outflow, which is the classic waveform from the hepatic veins. And then the portal venous, which is the inflow of the graft. So these three are the key components along from the biliary anastomosis that is performed by the surgeons, which leads to a successful outcome. Now, very important to know early on in the surgery. So what you see in this slide is not uncommon for any surgeon to see. So when an intraoperative Doppler is done or the Doppler is done on the first postoperative day, you would see that there is a sharp upstroke of the hepatic artery Doppler tracing, but you do not see much by way of flow in the diastole. And therefore, someone might get really psyched out of their wits that whether there is some impending doom going to happen for this patient. You could use a contrast enhanced ultrasound, as was done in this particular patient, wherein you could see that there is the hepatic artery, which is seen very well by the side of the portal vein. And very important from the perspective of both the surgeon as well as the physician is this so-called obsession with a RI of 1. So we all know that the resistive index, which is described by the peak systolic minus peak diastolic divided by peak systolic velocity of the arterial trace, the normal value is between 0.55 to 0.85. And when you have a high RI value, and that means that inherently you have a poor diastolic flow, that is the time when you start worrying whether this patient is going to have an impending thrombosis or not. So in the initial 24 hours, this might not mean much, but if the surgeon had encountered some difficulty in the hepatic artery anastomosis, you might be well served by getting a Doppler repeated twice over on the first day of surgery. Dr. Olivia already mentioned that different units have got different protocols to do the Doppler ultrasound exams. In our unit, we do it on a daily basis, at least for the first 1 week. But like I mentioned, that if there were some difficulties encountered during surgery, or the surgeon had to redo an arterial anastomosis, or they were not happy with the matching of the vessels, or there was some intimal tear, or this is someone who's already undergone a chemoembolization by the transarterial route and the vessels were not in great shape, you might want to do it twice over in a given day. So please remember that when the RI is more than 0.8 and there is loss of diastolic flow, the differential diagnosis is this is only a transient elevation or they do not see the diastolic flow, then you've made the diagnosis of hepatic artery thrombosis, and this would be confirmed by the cross-sectional imaging. Much later, days 3 to 4, then it's far easier because by this time your hepatic artery Doppler tracing, you would have a fair idea of what the values were in the day 1 and day 2. And therefore, you would know that if now there is a cessation of flow or there is an elevation of resistive index, then something is happening to this patient. She mentioned about the splenic steel syndrome, and that is again something that you see not on the day 1 or day 2, but later on in the first week of this patient. And then again, this is a situation in which the inflow through the hepatic artery to the graft is not very good. You ultimately have to diagnose this again on a catheter angiogram, wherein you would show on a celiac angiogram that most of the blood flow is going towards the splenic artery rather than to the hepatic artery. And then if you are able to correct the cause of this, you are able to coil the splenic artery, then you will find that again, there is a restoration of blood flow to the graft and the hepatic artery RI again becomes normal. Now let's talk about some real life case scenarios to drive home this point, because I think there is nothing more impactful than what you've experienced in a given patient. So like Dr. Olivia mentioned, hepatic artery thrombosis is one of the most dreaded complications after transplant, whether it is LDLT or DDLT. She also mentioned that the incidence is higher in reduced size grafts, which is what an LDLT is all about, because the vessels are much smaller and you do not have, the surgeon does not have the liberty to play with the length of vessels as they might have in a deceased donor transplant. So this is a story of a gentleman who was transplanted on our unit. He had secondary biliary cirrhosis due to hepatolithiasis. He had a MELD of 19. He had undergone prior laparotomies. And this again is something which makes the surgery difficult for the surgeon. Bad portal hypertension, more blood loss during the dissection phase. And at times you also have the structures plastered to the liver, which would again lead to more blood loss and more operating time. So this gentleman, for his hepatolithiasis, had undergone prior laparotomies in the past. He was a low body weight recipient. So again, this is one of the risk factors for the vascular complications that she alluded to. He underwent a left lobe living donor liver transplantation, graft with the middle hepatic vein, a GRWR of 0.9. And because his bile duct was diseased, the surgical colleagues preferred to do a Roux-en-Y hepatocogeginostomy right at the time of the at the time of the initial surgery, and the intraoperative Doppler was satisfactory. He was extubated on postoperative day 1. He was shifted to the room on postoperative day 2. He had a stable postoperative course, but on POD 3, the radiologist who actually begins the rounds for us on our unit showed that there was no hepatic artery Doppler flow signal. So briefly, this is what a Doppler should look like. And I think all of us, whether we are physicians, surgeons, or intensive care people, we should know what a normal Doppler is like. So there is a sharp upstroke. The systolic acceleration time is less than 0.28 seconds. And then you get a very good diastolic flow. And this is what a normal trace looks like. Somebody in whom there is impending doom, you would find that if this trace was like this on the first day and the next day you start seeing that there is no diastolic flow, then this is a patient in whom you are going to run into trouble. The lower panel shows that in the hepatic artery area, you do not get any signal at all. And then when you subject this patient first to a cross-sectional imaging to confirm the diagnosis, and then of course the most important way to diagnose is by way of catheter angiogram, you find that there is an abrupt cutoff at the anastomotic site, and that gives you the diagnosis of hepatic artery thrombosis. So this is exactly what happened to this gentleman who had a left lobe graft. So you can see that at the anastomotic site, there is no arterial twig which is going into the graft. However, the graft still looks well perfused. And this is what you see in another image of the same patient. You see some collections by the side of the hemigraft, which is not unusual in the early postoperative period. So patient was shifted to the OR. Like Dr. Olivia mentioned, that if this diagnosis is made early, the first thing that you want to do is to perform a thrombectomy and restore the hepatic arterial flow. Please remember that if this particular condition is diagnosed in the first 7 days, it might lead to an allograft failure. That means this patient might have enzymes running up to thousands. They might have elevated lactates, metabolic acidosis, derangement of INR. They might become coagulopathic. So everything that happens in a patient with liver failure might happen in a patient who's had a very fulminant course after a hepatic artery thrombosis. However, some people describe early hepatic artery thrombosis as within the first 3 weeks. Others describe it as within the first 1 month. But in the Western world, this particular condition is considered to be a status 1 patient if this is diagnosed in the first 7 days of the primary transplant and leads to allograft failure by way of the clinical and lab data that I just described. So this patient was shifted to the OR. He underwent a thrombectomy. The intraoperative Doppler showed that there was thrombus at the anastomotic site, which are surgical leaves removed. There were no clots seen in the hepatic artery branches intraparenchymally. What the surgeons would oftentimes do is put in a balloon like a Fogarty's and try to retrieve any clots that they see. At times, they would be putting in the intraarterial thrombolysis before they again refashion the hepatic artery anastomosis. And the Doppler spectrum showed poor flow in the end diastole, which I mentioned right at the outset is not unusual intraoperatively or in the first day post-transplant. So the patient was shifted to the liver intensive care. He was again extubated the next day. The percutaneous Doppler ultrasound showed a parvus et tardus pattern of flow, and the CT was repeated 1 week later. And this is what the CT scan showed. The graft again looks well perfused. We don't see any focal areas of altered density. But again, as you can see, that at the anastomotic site, there isn't any great inflow into the graft. And we would talk about the large series of patients who've been subjected to treatment that I just described. And this is another CT scan view of the same patient. So you can make out that this graft is really well perfused and you do not see any abnormality in the density. Now, very interesting to look at the lab data of this patient, because I have just learned from the last talk that this particular program in Uganda is going to embark upon transplantation. And it's very, very important to know that it is actually the clinical status of the patient as well as how the graft is behaving rather than the primary diagnosis that you've made. So as you can see on this chart, it's a busy slide. I will walk you through this slide that on POD3, the hepatic artery thrombosis was diagnosed. On post-operative day 3, the hepatic artery thrombosis was diagnosed. You can see that there was an elevation of the INR. You can see that there is a blip in the transaminases. You can see that there is a blip in the lactate values. And as you can see that this patient also started to have elevated drain outputs. And this patient ultimately went on to have a peak serum bilirubin value of 24 on POD day 2. It's also very interesting that as time passes by and you get a picture like this, the conundrum for the physician and the surgeon when they round the patient in the morning is how much of immunosuppression to give. So please remember, whenever there is an allograft dysfunction, the immunosuppression levels can vary widely. And as you can see, that because this patient was on low immunosuppression because of the repeat trip to the OR, this patient was running low levels. So it was difficult for us to see whether this patient was having the tests of abnormal liver functions because of the primary diagnosis, the surgery, the poor hepatic artery flow to the graft, or whether it was rejection. And oftentimes it might not be feasible to biopsy these patients, especially when they are coagulopathic, thrombocytopenic. You see over here a platelet count of 12,000, and when the drain outputs are very high. So as we would start to do the transplants, especially living donor transplants, at times you have to use your clinical judgment, even though histology remains the gold standard. So what we decided to do in this particular patient is to start going up on the immunosuppression, and this strategy worked well for us. And as you can see that on POD 26, this patient was discharged with with reasonable tests of liver function. I won't say that they were normal tests of liver function, but the drain output had decreased, the lactates had normalized. And of course, we do not run our patients on such high TAC levels. But like I said, that if you are giving the same dose, the TAC levels might fluctuate when you have got allograft dysfunction. So early hat falling liver transplant is defined as a hepatic artery thrombosis which occurs less than 30 days of the primary transplant. And if it happens and is diagnosed in less than 7 days, these patients are put up for super urgent listing. They become status 1 patients in the Western world. The incidence is about less than 5%. It's higher in the pediatric age group than in the adults, and the median day of occurrence could be day 7. However, many times you would pick up these patients even on day 2, 3. Most of these patients undergo retransplantation, and these are far commoner in the pediatric age group than in the adults, and the mortality associated with this condition is extremely high. Most of these patients become biliary cripples. There would be parts of necrosis, as we all know that the bile ducts are supplied with their vasculature or with their blood primarily through the hepatic artery and its branches, and therefore you get the bile cast, you get the debris, you get the necrotic biliary epithelium that can lead to infarct, collection of abscesses and necrotic areas in the liver, and these become very difficult to manage medically or by way of intervention radiology, and many of these patients will end up undergoing transplants, retransplants. The technical reasons have already been alluded to by Dr. Olivia, and in the interest of time, I would not detail them. Now, I would request all of you to read this paper, which is of course about 14, 15 years old, but this is the experience from UCLA in the US, and this is the experience on more than 4,000 transplants. And as you can see, the early hat was diagnosed in about 133 patients in this cohort of 4,000 transplants. Revascularization was attempted in 2/3 of the patients by way of thrombectomy, and the graft could be revascularized only in 10 to 30%. So this is a very, very important figure for us to know. Even in the best hands, you would not be able to achieve the revascularization in more than a third. Thrombolysis and revascularization by leaving a catheter over there and then using some kind of a thrombolytic agent is again something which works only in about 15% of patients. Many of these patients would be subjected to retransplantation. However, it is very important for us to know that if you had a patient who's got a well-perfused graft and who's undergone probably something like a biliary enteric anastomosis, if you do not see the features of lactate going up, INR going up, or if you do not see somebody going on to become encephalopathic, then it might be quite all right and reasonable if imaging has showed this graft to be well perfused to only observe. So in our patient, why did I try to present this case? Do you think that shifting to the OR helped? Probably not. I think he was as well served by just having been observed rather than having been taken to the OR. And over here, of course, the advantage was the biliary enteric anastomosis. And this is because the jejunum has got a very good vascular arcade. And once you have hemigrafts, they tend to pick up the blood supply from the intercostals, from the phrenic, and from the intestines. And that is why these grafts, they are looking well perfused, even though the main arterial supply is conked off. However, you could accuse me of having been rational and intelligent on hindsight, and I would concede that. I think most of the surgeons would be very inclined in a given patient, especially when this condition is diagnosed in the first 24 to 48 hours, to take the patient back to the theater. But centers with large experience would understand the importance of just observation if your patient is not having features of graft failure. Now, another large experience from the Birmingham group in the UK, they describe the hat falling liver transplant as early versus late. And as you can see, the late group is larger than the early group. Again, this is about 1,500 liver transplants. They found E hat in 31, late hat in 71, and no hat in 1385. This is a table which shows you just how the patients with late hat present. And it could be anything from raised transaminases to ischemic biliary lesions to incidentally being discovered just on a routine follow-up ultrasound. Some features of graft dysfunction, very occasionally patients presenting with an allograft loss, pretty much as you see in early hat. And then some patients would be having just cholestasis. So it is very important to remember that in some studies would show that both the patient survival and the graft survival suffers. whereas the experience from the UCLA group, which I alluded to a little while earlier, they showed that only the graft survival was inferior in patients who underwent early HAT, but not the patient survival. On a multivariate analysis from this Birmingham experience, these are the various factors which are relevant for E-HAT, and at the bottom of the table, the factors which are relevant for L-HAT. Oftentimes, you would see that the patient who's been discharged comes back for his routine OPD visit, and somebody who'd had a normal Doppler arterial waveform, the radiologist comes back to tell you that I am seeing now a tardus parvus. So this is a slow rise, a prolonged systolic acceleration time, and a low RI, a RI value of less than 0.5. However, if you were to insonate this patient more proximally at the site of the anastomosis, you do not see any signal of hepatic artery at all. And once this patient underwent first a cross-sectional imaging and then a catheter angiogram, you see that you are able to demonstrate the hepatic artery thrombosis, so no arterial inflow into the graft, but you can see the twigs of the vessels in the hepatic parenchyma. So this is the patient who probably thrombosed off a little while ago or some days or weeks ago, but now the graft is reperfused by the collateral flow. And this is exactly what you see in this particular patient. This is again one of our patients who had a graft revascularized through collaterals. You can see that the collateral density is higher in the right lobe than in the left lobe. And indeed, this patient did had a sequelae to this in the form of a caudate abscess. And you can see the segmental dilatation of the left bile duct, left hepatic duct. So this is very, very important that the hepatic artery issues would produce kind of biliary sequelae, as well as areas of necrosis and abscess formation in the liver. Was this patient managed medically? The answer is, well, yes. And this patient continued to have normal graft function for a significant length of time, was not subjected to any surgery, repeated endoscopic or interventional radiology procedures, other than tweaking the immunosuppression and draining the abscess. Now, quickly coming to the second important complication after liver transplantation, and that is an early portal vein thrombosis. So like Dr. Olivia alluded to the fact that at times portal vein thrombosis can produce an allograft failure. So let's again run through a clinical case. So this is a gentleman who had cryptogenic cirrhosis and who had portal vein thrombosis with calcification. So please remember, one of the most important predisposing factors for portal vein thrombosis in the liver transplant scenario or in the graft is the existence of portal vein thrombosis in the patient prior to the transplantation. He had recurrent photosystemic encephalopathy and was typically a low melder. So these are the patients, even then the meld is low, but because they are incapacitated by the recurrent episodes of HE, they undergo transplant quite commonly. He underwent a right lobe living donor liver transplant with partial MHV. The PV thrombectomy was done with good forward flow. It was a single hepatic artery anastomosis, and the donor right hepatic duct was done to the right common hepatic duct of the recipient, and duct-to-duct anastomosis was done, and the intraoperative Doppler was fine. He was extubated on POD1, shifted to the room on POD2. On POD3, the Doppler ultrasound showed the presence of thrombus in the anterior branch of the right portal vein. So this is this patient's evaluation CT. You can see that there is hardly any portal vein that you can see, and there was calcification, though you do see some intrahepatic twigs of the portal tributaries. Now, what happens to this patient's test of liver function? And that actually I wanted to be the mainstay of my presentation today. So you can see that once the portal vein thrombosis was diagnosed, this patient's INR again begins to go up. His bilirubin does not change very much at this stage. The lactate goes up transiently, but most importantly, formation of ascites. So the drain output increases tremendously. So a portal vein thrombosis is characterized by transaminitis, presence of ascites, an abnormal INR value, and at times these patients can again go back into encephalopathy. And if they present with the features of graft failure, then they might have to be again relisted for a liver transplant. At times, if these events have not happened, you could just anticoagulate these patients and see if the graft is well perfused to just manage them medically. This is exactly what we did on our patients. So you can see the periportal edema. You can see that there is only a streak of flow at the anastomotic site, and around the sides you see the presence of the thrombus. On another section, you can see on the coronal section, you see these areas of hypodensity, which is the tissue which is deprived of the portal inflow. It looks very ghastly, but you have seen the kind of the test of liver function this patient had, and as they improved over a period of time. Another message in this particular case is you can see the collaterals. So you can see that this patient had got a lot of splenic collaterals, and if you were to see the patient's pre-operative CT, again you could see a lot of collaterals in the splenic hilum and in the vicinity of the kidney. So oftentimes when surgeons do the thrombectomy, they would look at the portal inflow. If the portal velocity is more than 20 to 25 centimeters per second, at times we would not touch the collaterals that have been picked up on the pre-operative imaging. However, if the inflow is not very good, at times we would try to handle these collaterals by ligating them. And if we find that it is difficult to reach out to them, and many of them are draining into the left renal vein, the surgeons might just want to ligate the left renal vein so that the inflow to the portal inflow to the graft can be augmented. So this particular patient we managed conservatively by giving him systemic anticoagulation, and this patient was discharged with normal allograft function. However, he continued to have a degree of hypersplenism, which was manifest as a low platelet count. 3 years later, he developed a portal vein stenosis and underwent portal vein angioplasty and stenting. So Dr. Olivia has already shown you some elegant images of how to diagnose portal vein stenosis. You can see that there is the narrowing at the anastomotic site, and this is called aliasing. And this is a very, very important phenomena to diagnose that there is an obstruction in a vascular anastomosis. More proximally, the velocity was low, and at the site of the anastomosis, the velocity was extremely high, 206 centimeters, and this gives you the diagnosis of portal vein stenosis. We went by the transhepatic route, and this is the wire gone into the superior mesenteric vein. A balloon was placed. You can see the waist here, which tells you that this is the site of the narrowing of the portal vein at the anastomotic site, and this patient was stented. So what about the experience in large series? Again, going back to the UCLA series of 4,000 plus transplants, the portal vein thrombosis occurred in just about 2% of these patients. The risk factors have already been alluded to. The presentation is in the form of transaminitis, ascites, high drain output, GI bleed, and in a small proportion of patients features of allograft failure. Many of these patients who develop allograft failure would need to be relisted for transplant. So it is very important that at least in this particular series, the authors felt that unlike hepatic artery thrombosis, PVT was not more common in pediatric transplants, even though extrahepatic biliary atresia continues to remain one of the commonest indications for transplant in the pediatric age group. And oftentimes these patients small children, they have got very difficult portal revision thrombectomy, retransplantation, catheter-based therapy, and photosystemic shunting. And it has been shown that portal vein thrombosis, unlike the hepatic artery thrombosis, where only the graft survival is inferior, but patient survival is same. Here, both the graft as well as the patient survival is inferior to those who do not develop portal vein thrombosis. In single center studies from in the living donor liver transplant context. So mind you, the earlier study was in the deceased donor context. So here you are dealing with half grafts. This is one very good study which got published in liver transplantation about 3 years ago. Herein, the authors from this single center in Japan have described all the portal vein complications as PVCs, and they have classified them into 3: portal vein stenosis, portal vein thrombosis, and portal vein occlusion. And they have shown that pretty much how the surgeons and the radiologists describe the portal vein thrombosis by the Yerdle classification. If you have got someone who's got just a portal vein stenosis or a Yerdle grade 1 PVT, they do very well. However, if you have got someone who's got a portal vein occlusion or a Yerdle 2 to 4 PVT, these patients have got an inferior survival for the graft as well as the patient. And this is the management algorithm which these authors followed. you can see that if you had an early portal vein complication, the denominator is 14, but in 13 you were able to restore. Whereas if you have a late portal vein complication, again the failure rates are pretty high and you are able to get success only in a short proportion of patients. So this is very important to remember again, that this complication should be picked up in a timely manner. Now again, a very interesting study which was published from Rotterdam, which actually emphasizes on the importance of doing regular Doppler ultrasound in these patients. So I would again recommend everybody to go through this study. This is not just for HAT or PVT, but also hepatic venous outflow obstruction. And the most important thing which these authors set out to study was what was the diagnosis made within the first week of transplant. So of the 708 transplants performed, 21 liver vascular complications were picked up in the first 7 days. 7 of these patients were anticoagulated, 14 were taken to the theater, and you can see that many of these patients, the graft was saved. In up to 60% of the patients, the graft was saved, and the number of patients who needed an urgent retransplantation or a late retransplantation is indicated here. Why I like this study very much is because this is more representative of what we do in contemporary practice. So mind you, the UCLA experience is about 14 years old, and in those days, the DCD grafts were not very common. So herein you can see that at least a third of the grafts were the DCD grafts, where again the vascular complications have at least been slated to be higher than the DVD grafts. And a proportion of these patients were living donor. Machine perfusion was used in about 1/6 of the patients, and the surgical characteristics are also what you would very commonly see in your day-to-day practice. So this is the summary slide. It's very, very important to pick up the vascular complications early. The 2 complications that I alluded to by way of case scenarios was an early HAT and an early PVT. In one, we took the patient to the theater. I don't think it helped much, but maybe that's a comment made in hindsight. And in the other patient, we felt that this patient could be managed with conservative treatment by way of just anticoagulation, and that is exactly what we did. So the Rotterdam experience was that if you do the daily ultrasounds, you are able to pick up these 3 complications early, HAT in 7%, PVT in 8%, and venous outflow obstruction in 3%. The median time to these complications is shown over here, and it is highest for PVT. And a day-wise pie chart has been given in this study to describe how many events were picked up. And as can be seen that in at least 58% of the patients, you will be able to salvage the graft. So I think these case scenarios very elegantly demonstrate the fact that if you had some technical difficulties in the operating room, they can come back to haunt you in the post-operative period. Keep the threshold for doing the Doppler ultrasound very low. At times, these patients might be served well just by observation, and I try to highlight as to what are the patient characteristics which would help you decide in favor of just observation rather than an intervention. I thank you very much, and once again, I would want to express my gratitude to the Ugandan Society of Surgery and Liver Transplantation for this opportunity given to us to share our experience. Thanks very much, and I would be very happy to take any questions.
Thank you very much, Dr. Dharmesh.
Any questions, comments? Okay.
Just a comment.
Very well received, and the message is clear to keep an eye out for complications at all times. And we shall be doing this. Actually, we're in the process of writing our protocols for liver transplant, and we shall make sure we include all these recommendations and make sure we keep an eye out for complications. Catch them early, deal with them appropriately for the best outcome for our patients. Thank you so much, Dr. Dharmesh.
Yeah, I think Dr. Olivia wanted to make a comment.
Okay, she's free to.
Yes. Thank you, Doctor, for the very, very good presentation. I think what you have brought out, which is a key factor as we venture on this liver transplantation, is the importance of clinical assessment and the strict follow-up of these patients with the labs, because the tables that you presented of the lab results and how frequently and how meticulously these are followed up to be able to detect changes before we even have to go all the way to other radiological investigations or to have a high index of suspicion. I think that's another take home, that we combine that with the clinical presentation, and we also look very closely at the lab investigations and the drains and things like that that help us be able to diagnose this before even, or know when to go ahead and do some of the investigations, mainly because we may not necessarily have these investigations very readily on hand, although ideally they should be there, but we should be able to have a high index of suspicion just based on the clinical features, based on your lab, a strict follow-up of the lab investigations on a daily basis and charting these. Thank you.
Yeah, I completely agree with you. So I think you have to have a very low threshold for getting a Doppler ultrasound done, and very keenly keep an eye on what's going on with the patient profile, because it's not always very beneficial to take the patient to operating room. So the UCLA experience I wanted to present, because we are talking about something like 4,000 transplants, and that paper was published in 2009. Of course, there haven't been too many recent publications on vascular complications with liver transplant. But of course, many parts of the world, we are now doing hemigrafts, and of course, these complications are much higher. However, the surgeons have also become extremely good and skillful by the use of, say, operating microscopes or loops and better suture material and, better matching of the blood vessels. However, it's not unusual that in sick patients, you might have things going wrong in the operating room. In the interest of time, I didn't talk about this, but there are strategies on thromboprophylaxis, then use of the factor concentrates intraoperatively, use of antifibrinolytics, which you briefly mentioned. So all these are very, very useful things to know when you want to prevent these thrombotic complications.
I want to make a comment. Thank you very much, Dr. Kituuka and Dr. Dharmesh Kapoor, for very excellent presentations. I just wanted to ask Dr. Kapoor about the role of simple things like nursing care. If you underhydrate, if you don't give your IV fluids on time, does it have any role in predisposition to hepatic artery thrombosis or any vascular thrombosis? And also, right, as an anticipation, because you want us to anticipate and not wait at the tail end. So just simple fluid giving. And then the other comment I wanted you to comment on is the issue of HB. Sometimes people are too ambitious to over-transfuse. And does it have any role if you have to have a high HB of 15 or plus versus the one of around 10, 11 in predisposition to this thrombotic phenomena? I just wanted you to give us if these fears are genuine or not. Thank you.
So I think both these are excellent questions. Now, first coming to the fluid part of your question. Now, most of the times when these patients are shifted from the operating room to the intensive care, in our unit, we would be giving them maintenance IV fluids. So all of my colleagues who would have worked in transplant units would be aware of the fact that at least in the first few days of liver transplantation, the patients are generally in a positive fluid balance. However, this trend has to rapidly change come day 3, day 4, that these patients must first start to get into a neutral fluid balance and then start to get into a negative fluid balance. You can never ever discharge a patient post-transplant if this patient has not been able to achieve a negative fluid balance. So we all know that during surgery, there's so much of blood loss, so much of fluid fluxes that are happening. that it's not unreasonable to see patients being at least positive by say 1.5 liters up to 2 liters also at times in the first 3 to 4 days. So therefore, the role that the fluid therapy or lack thereof has to play in the early thrombosis is not there. However, late hepatic artery thrombosis is a poorly studied thing because many of these patients have been discharged to home, and one believes that maybe some such event in which the patient got dehydrated could have predisposed this patient to a late HAT. So long story short, in early HAT, this might not be relevant, but in late HAT, it might be relevant. Now coming to your second question of the transfusion. So again, very, very important for programs at the threshold of starting out that please have set transfusion triggers for your program. Gone are the days that we would be looking at double-digit hemoglobin values. A value of say 8 to 8.5 or 9 would be perfectly fine. I would go for a value more than 9 only if there is some comorbidity in a given patient, especially a cardiopulmonary comorbidity. So we must understand that you have to keep your blood thin. You don't have to make your blood more viscous by over transfusing them. Not just the immunological benefit, not just the cost benefit, but also these patients would be rheologically much better off by being managed at hemoglobin values of between 8 and 8.5. So every unit must have their transfusion triggers. We should not be indiscriminate. If the field is oozy, use a point of care or a viscoelastic test to decide whether this ooze is indeed because of coagulopathy or whether it is only surgical. So I think these are very, very important points to ponder over while the patient is in the operating room and in the first 2 to 3 days in the intensive care.
Thank you very much for that very important clarification. I hand back to Dr. Lobo.
Thank you again to the presenters and the audience for participating. It's a very good turnout here that you may not be able to see. Mr. President, we are doing well on your behalf. And at this juncture, some questions? Okay, some more questions from the audience.
Thank you very much for the presentation. My question is in regards to patients who get hepatic artery thrombosis and already have features of sepsis that is probably getting necrosis in some areas. Do you usually plan for a backup donor in case you find that liver and salvageable, or there are always options for those patients? Thank you.
Any of our presenters may want to respond to that?
I'm sorry, we didn't hear it. It wasn't very clear about, do they do a backup? Something about the backup, something we didn't hear very well.
So the question is, if there's hepatic artery thrombosis and there is sepsis, and there's perhaps consideration for retransplant, how do you plan and anticipate that and prepare for it?
Dr. Olivia, I can hear a lot of echo. Could you I can only hear you very clearly. Could you repeat this question, please, for me?
I think they're asking about hepatic artery, if there's hepatic artery thrombosis and there's sepsis and infarction, and is there, and the patient requires a retransplantation, how do you prepare for a backup I think a backup transplant, something of the sort.
All right. So I think, like I mentioned, that in the Western world, these patients would be listed super urgently, but that is only for the hepatic artery thrombosis, which is 7 days into the primary transplant. And this situation of sepsis, infarction, necrosis, abscess formation is pretty much similar to what one sees in patients with, say, secondary biliary cirrhosis or PAC, where it is believed that this sepsis is confined to the graft. So it does not become a contraindication to transplanting this patient. Of course, the surgeons should be well aware of what the primary anatomy was they should also be willing to use a conduit in these patients, because the arteries in the recipient have already been used once. So it is not unusual for in the retransplantation for the surgeons to be using the aortic conduits as the inflow. And in the rest of the world, where you do not have access to diseased donor organs, or where you do not have the system of super urgent listing, you would have to manage this patient till such time another donor becomes available, either in the deceased donor context or in the living donor context.
Okay, thank you for your response. I think there are no other queries on our side. Okay, one last one.
Thank you for the presentation. My question is more to the event thing. From the complications that presented, most of the management, as part of the management, involves intervention in radiologists. So from our side, since we're planning to start, our intervention radiologists trained to manage these complications.
Thank you very much. I think Mr. President will make a comment on that, but I know the teams are being put together. This, as you've noticed, is a multidisciplinary venture. So both Rubaga Hospital and Mulago Hospital are now putting together the teams to prepare towards transplantation. And at this juncture, I'd like to invite the President, Dr. Michael Kello, to make a few remarks and give a vote of thanks to our presenters. Thank you.
Thank you very much, Dr. Lobo, and thank you everyone for joining in. And just before I give a vote of thanks, I want to comment on the question on interventional radiologists. They are very important as we go to all these advanced and complex surgeries. And in the country, I'm happy because Mulago is already started a fellowship in interventional radiology. I know it's still at its infancy, but it's a good start and it will keep improving. One beauty about starting these programs is that it forces the entire system to improve. And I'm happy, even during our training, all this was in place. We had an interventional radiologist. Unfortunately, ended up, I think, going to Namibia or Botswana, one of those countries. But we have Dr. Hassan around. He's polishing up his skills. He keeps going back, and now he's able to do. We've been in touch. He's beefing up even his supplies for endovascular interventions. So preparations are on the way, and our role as experts is to try to push the system to change. We can't just sit back and wait for things to happen. We have to try to do something. And all these things are being done. And to end that, this is also today's presentation also happens to be part of the World Liver Day. And I thank our senior consultant from Yashoda. I've been to Yashoda. I happened to scrub in one of their cadaveric transplants when I visited there, but that was before Dharmesh Kapoor, I think, went there. It was the time when we had Bala. Bala moved to AIG, and it's a very beautiful hospital. I met the owners, one of the owners, and they are very supportive in terms of supporting Africa in advancing. And I asked Dr. Dharmesh Kapoor, when we start, we'll contact you definitely for your team to support us. Thank you very much, Dr. Olivia, for the presentation. Thank you very much, Dr. Dharmesh Kapoor, for that nice presentation. And thank you, everyone, for this. And thank you to our sponsor, Mega We Care. Unfortunately, I'm not able to be there physically. I'm actually in the US attending a cholangiocarcinoma conference. And my presentation was yesterday. I was worried I would not be able to attend this, but I'm happy I've been able to attend, and it has been very enlightening. I thank you all, and I wish you the best. Thank you.
Thank you. Good night. And you have all the support that you need from our end. You could pick up the phone and talk to us any time of day or night. And if you have people who are keen to come and work, whether on the IR side or on the intensive care side, or surgical or medical colleagues, more than happy to host you at Yashoda. Thank you.
Thank you very much. Thank you very much, Dr. Kapoor, for that invitation. We will always give a call to you. And thank you, everyone. Bye-bye.
So now we take a listen to Mega We Care. Mega has shown us that they care about us, and they care about SUGES. Now they don't care for our patients. So,
thank you very much, sir. Very, very good evening to all of you from Mega Life Science. Actually, Doc, this journey has been started from January. And January, Feb, March, and April, today we are concluding the liver transplant and its complication. That was our topic in last 4 months. The SUGES has covered. And there is a beautiful coincidence today. Today is a World Liver Day as well. Okay. So by knowingly or unknowingly, we are ending up with the liver transplant on the right day. So today we all are here. But before we go into the end session, I have some small presentation, not for the liver transplant related something, but how we can delay the liver transplant. Okay. So over there we have 2 products which can add certain value in your clinical practice. So that I am going to cover. So that's why my topic is management of cholestatic liver disease. Is life without living? It all depends on the liver. If we see the global prevalence, which was published in Hepatology 2023 in month of April, data was collected from 1990 up to 2019. The global prevalence is almost 30% of non-alcoholic fatty liver disorder. But when we look into the MENA region, that is the Middle East and African region, almost 36.5% patients they are suffering from non-alcoholic fatty liver disorder. Although this data is not fully covered African region, because very few countries submitted their data. But if we see the global rate of NAFLD increasing over the time, since 1990 up to 2006, there was only 25%, which was touched almost 38.2% in between 2016 and 2019. So this complication has been increasing. So worldwide, there is a 36.4% prevalence of non-alcoholic fatty liver disorder. The percentage of total death, all cause attribute to NAFLD is increase also 0.1% to 0.17%. And NAFLD represent the second leading cause of liver transplantation. So before your patient reaches to the liver transplant, we has to control or we can delay the progression. That we are going to see through some clinical trials. And that is one of the leading cause among the females as well. The metabolic risk factor in the children and adolescent constitute one of the biggest threat to the global health in coming decade. If you look into the African region, they are estimating around 13.5% risk of NAFLD. Only 3-4 region has been covered here. 9.5% patient with type 2 diabetes reported with NAFLD in Nigeria, and without type 2 diabetes, there is 4.5%. 73% patient reported in type 2 diabetic clinic in Ethiopia, and 87% obese and overweight. They also reported in Western Cape and South Africa. Higher rate of obesity impact the HIV infection, which also increase the risk of NAFLD among our patients. But when we look into the Ugandan market or Uganda, the liver disease, one of the top 10 cause of reducing the life expectancy in Uganda. So far, 5,122 patients died due to the liver complication in Uganda. NAFLD is most common chronic liver disease among this patient. The prevalence of NAFLD estimated to increase with the rising case of diabetes, HIV, and obesity in Uganda. As per the WHO estimate, Uganda, 5,122 patients, almost 2.47% patients, those who die in Uganda, that is from liver-related complication. So I'm not going to teach you deeply about NASH and NAFLD, but just for small understanding, this is the healthy liver when the fat deposition increase or patient reported with steatosis more than 5% fat deposition in the hepatocytes, that is considered as NAFLD, non-alcoholic fatty liver disorder, and steatosis with inflammation and fibrosis is considered as a NASH. And when it worsen, then there is a cirrhosis happen, and over there, liver transplant coming for the patient. What are the risk factors? Like type 2 diabetes patient, obesity, hypertension, and hyperlipidemia are the major risk factors. But it's commonly seen in type 2 diabetic patient because they are directly linked to each other. If patient is suffering from NAFLD, there is a twofold higher risk to develop type 2 diabetes. And type 2 diabetic patient increase the risk of faster progression of adverse fibrosis. NAFLD amplified the cardiovascular complication risk in the type 2 diabetic patient, and type 2 diabetic patient amplify the risk of liver-related mortality caused by NASH, non-alcoholic steatohepatitis. We already seen the global prevalence, but the global prevalence of NAFLD in type 2 diabetic patient is on an average 55%. When we look into the Uganda non-alcoholic steatohepatitis, which has been covered with the several studies, almost 37.3%, and 7 studies shows the adverse fibrosis in the patient with NAFLD in type 2 diabetic patient. Obesity is also one of the biggest cause to cause the fatty liver in our patient, especially when we look into the Uganda. Overnutrition, insufficient activity, poor diet, low fruit and vegetable intake cause NAFLD in obese patient. In Uganda also, the obesity is increasing like anything. Since 1995, it has been increased 7 times in 2015. By 2030, they are expecting 7 people out of 10 people has a risk of obesity in Uganda. That is also one of the biggest cause to cause NAFLD or NASH, or our patients suffer from liver-related complication. So there are certain diagnostics process are there. The gold standard is always biopsy. As per American Academy of Study for Liver Disease guideline, there is a hepatic steatosis by imaging or the histology, no significant alcohol consumption, no a cause of CLD, and etiology of other complication. Non-alcoholic fatty liver disease is the most common cause of elevated liver function test in the result after the commonly investigated cause been exhausted. So there are officially no treatment is available which is recommended in terms of medication for NASH or NAFLD. Lifestyle modification is the treatment which is recommended. But there are several drugs are available nowadays in the market which also treat or reduce the NAFLD or NASH in our patient or further progression of liver cirrhosis in our patient. So there are certain clinical trials which I would like to share here. There is a role of UDCA, that is ursodeoxycholic acid, for the management of NAFLD. This study was published in Netherlands in 2022 in Gastroenterology and Liver Conference. In this study, over 1,548 randomized control trial has been reviewed since 2004 to 2018. Over the 15,000 patient has been enrolled. An outcome measure including both decrease the liver transaminase, improvement of histology, follow-up period from 4 to 96 weeks. Result came that 1,548 randomized clinical trial reviewed 2004 to 2018, 85% of randomized control trial shows the decreased transaminase and improve the histology of the patient liver. Hence, UDCA showing the parsinoid targeting mechanism may yet to become a frontline therapy, because we all know UDCA is used for the management of gallstone. In this review also they are saying it may yet to become a frontline option for the NASH or NAFLD. thereby preventing the progression of cirrhosis and liver cancer among our patients. There is also SGL2 inhibitors versus ursodeoxycholic study has been done on 240 patients. SGL2 inhibitors, they use empagliflozin, and they find basically the change in liver fat content among our patient. So result clearly shows that UDCA improved the liver fibrosis score and insulin resistant more than empagliflozin, as well as both drugs were comparable, decreasing the liver enzyme and BMI. So whenever you have patients, those who are suffering from type 2 diabetes, you can use empagliflozin or ursodeoxycholic acid. This study is concluded. Also, the efficacy of ursodeoxycholic acid for the treatment of non-alcoholic steatohepatitis, a systematic review. The data has been collected from PubMed, Web of Science, EMBAS, and Cochrane, and data has been collected before 1st January. Result shows that total 8 study with 655 participants met the criteria for inclusion of this meta-analysis, and they find UDCA treatment significantly reduced the ALT and GGT among this patient. Hence, UDCA thereby effectively reduced the serum level of ALT and GGT in the patient with NASH. So not only ursodeoxycholic is recommended for the management of gallstone, but is also recommended for the chronic liver cirrhosis, liver disorders, or what we call cholestatic liver disorders. Because ursodeoxycholic acid has shown the cytoprotective, immunomodulatory, and membrane stabilization, anti-apoptotic, and antioxidant activity among this patient. There is also one more molecule is that for the management of or improve the liver management. That is EPA, what we call essential phospholipid like phosphorylcholine. So phosphorylcholine supplementation benefit the enhance the membrane fluidity and restore the membrane integrity among our patient and normalize the membrane dependent fraction, improve the liver metabolism, reduce the cell death, fibrosis, hepatic steatosis, and prevent liver cell damage caused by the various etiology, help in maintaining the membrane integrity. There are several studies has been conducted for the management of essential phospholipid in the liver complication. Also, there is a phosphorylcholine in the chronic liver diseases. The recommended double-blind trial, they shown the marked decrease in the patient liver function test. By alcoholic liver disorder, 30 clinical study has been conducted. 15 was randomized trial. The fatty liver, hepatic, and cirrhosis, they recommended 1.8 gram per day for oral for 4 to 6 weeks. And non-alcoholic fatty liver disorder, 53 clinical trial has been recommended 1.8 milligram for 4 to 6 months. 4 weeks to 6 months, sorry. Apart from this, we all know that vitamin E play a very vital role in the reducing the oxidative stress, and B vitamins rejuvenate patient liver faster. Moreover, that we also have a livolin trial which has been conducted in Ukraine for the management of non-alcoholic steatohepatitis. In this group, 116 patients enrolled, and group 1 received 2 capsules of livolin 4, and group 2 received the basic treatment for 8 weeks. They also find the marked decrease in the parameter of AST and ALT. This particular trial has been conducted with livolin 4. So this says that the complex therapy of patients suffering from NASH with 2 capsules of livolin 4 taken 3 times a day for 8 weeks can be recommended as a efficient method. No side effect or other effect were registered in the course of the therapy with livolin 4. Also, this study has been conducted in Nigeria for assessment effectiveness of the livolin 4 in the treatment of patients with steatohepatitis. This shows that livolin promotes the rapid arising the clinical symptomatology, and normalizing the biochemical indicators among their patient. Over there also 2 capsules of Livolin-4 recommended 3 times daily. Duration was 8 weeks. So whenever your patient, those who comes to you, those who are suffering from NASH or NAFLD, before they land up to the liver transplant, because that is a costly treatment, isn't it? For so many patients travel from Uganda to different part of the world for the treatment. Half of that patient has to sell their property also. Am I right or wrong? So when you find your patient about to reach that stage or they are progressing to the liver transplant stage, we can slow down the progression with the help of Ursolil and Livolin-4. So both product is available in Ugandan market. The major thing here I would like to highlight the dose of ursodeoxycholic acid, that is a brand of Ursolil. Because normally in Ugandan practice, we observe doctors are prescribing 1 or 2 capsules only, but that doesn't add a value. This international dose they are saying when the patient, those who are suffering from cholestatic liver disorder, patient has to be prescribed 13 to 15 milligram per kg body weight per day. That is the ideal treatment. Even the patient, those who are suffering from gallstone, they has to be recommended for 8 to 10 milligram per kg body weight. So please, whenever you are treating your patient either from gallstone or the cholestatic liver disease, please prescribe them a right therapy dose and guide them. It's important. And Ursolil is the only brand in Uganda which has a bioequivalence to the innovative brand. The first brand in Uganda. For the management of NASH, NAFLD, gallstone, primary biliary cirrhosis, wherever you find your patient suffering from liver-related complication, Ursolil is always there. And whenever your patient, those who are suffering from liver-related complication and you want to supplement to improve their liver parameters, Livolin-4 is always there. Livolin-4 is the brand of post-choline. We are offering 300 milligram with B vitamins, which help to rejuvenate your patient liver faster, and vitamin E to protect your patient liver from the free radical damage. So this brand is also freely available in Ugandan market for the management of your patient liver. That is Livolin-4. So on this occasion of World Liver Day in 2024, we would like to say thank you very much to all of you for coming here physically and attending this session. With this, thank you very much from Mega Life Science, from Livolin-4 and Ursolil. Thank you.
Thank you. Any exhibitions, others?
Yes, sir.
Right. Thank you for the presentation. You mentioned something about was it substituting SGLT2 inhibitors for UDC?
Yes, sir.
So maybe I would like to get some clarification about that.
Actually, SGLT2 inhibitors not only used for the management of type 2 diabetes, also has some role in the liver management. So that's why they compare SGLT2 versus ursodeoxycholic acid, but not for the type 2 diabetes, for the liver. If you see this trial, this is a trial which has been published in 2022 Pharmaceuticals Journal. So they compare SGLT2 that is empagliflozin, which is currently as of now is not available in open market officially. It's just off patent and coming soon to Ugandan market, empagliflozin, which shown some marked improvement in the overall liver parameter in type 2 diabetic patient. But when you compare empagliflozin with ursodeoxycholic acid improve the liver fibrosis score and insulin resistance in more than empagliflozin. But that doesn't mean that you replace the therapy of type 2 diabetes patient. Yeah.
Thank you so much. Thank you so much. Considering Ursolil, at some point,
Yes.
but it shows that without that, the impact of exposure is almost significant.
Not possible. Or goes to your hand, right?
Please, say that now. This is that we can start with the question of break down these things and then just hear them the activity and then have the separation and then they are actually become more with some of the Spanish shows that help the impact of the drugs there's no so how should we bring up that previous and or change?
Ma'am, actually, basically, ursodeoxycholic acid is considered as a secondary bile acid. Normally, our body produces it in ratio of 4 to 5%. Basically, primary bile acid is collected into gallbladder, goes to the intestine in presence of bacteria, and gets converted into the secondary bile acid. That is a normal process in our body. Okay. Now, when our body is not able to produce the ursodeoxycholic acid, over there, the supplementation of drug is required. Okay, that is a UDCA. That is synthetic form, that is ursodeoxycholic acid. Now, basically, ursodeoxycholic acid can be used in the management of gallstone when gallstone is non-calcified radiolucent. Okay. If your patient gallstone is not resolved, that means stone has been taken. Over that, surgical remedies remain. Now, post-surgical phase, why we need ursodeoxycholic acid? Basically, ursodeoxycholic acid role is to digest the cholesterol within the intestine and avoid the redepletion of the cholesterol on the liver. When our body don't have primary bile acid collection or the gut, and it directly goes to the bloodstream. So something is required to digest that cholesterol and avoid the redepletion of the cholesterol. So fatty liver, NASH, NAFLD, those kind of conditions we can avoid it. Liver, our body energy work very normally. This information basically I received from one of the oncologists in Uganda, gastro-oncologist. He said that most of the patients what we see in UCI operated through the gallstone, they remove the gallbladder. After 3 to 4 years, they reported with malabsorption, and they suffer from diarrhea for long period of time. So over there, ursodeoxycholic acid reduce that malabsorption by improving the digestion within the intestine. But sincerely speaking, I don't have any clinical trial as of now, okay, which can give a scientific backup. But definitely I will cross-check with my medical team, and if I get something, maybe we have upper GI bleeding, right? Next topic. Over there, if I get a chance, I will definitely present how to use in post-surgical cases. Thank you.
Thank you very much. Yeah, like you said, the next series is biliary disease, so we shall be dealing with some of those things. You can continue the conversation.